Thank you all very much for coming out on a Thursday night in Melbourne. It's no mean feat to get around Paran, and I thank you very much for coming here and taking on the traffic and the parking. So tonight I'm going to talk to you about obesity, and I guess it's important that when we start out we know what we're talking about. And obesity, defined medically, is an abnormal or an excessive amount of fat that presents a risk to health, and that's how it's been defined by the World Health Organization. So how would you know if you're obese? Well, there's a couple of ways of doing it, but the two most common ways that we use in the clinic is to measure either your BMI or your waist circumference. Your BMI is your body mass index, and you calculate that by taking your weight in kilograms and divide it by your height in metres squared. And if your BMI, if that number comes to over 30, then you are considered obese. If that number comes to over 40, we would say you're severely obese or morbidly obese. And if your BMI comes to over 50, we have a new category recently, sadly, called super obese. The waist circumference is another way that we can measure obesity, and in women that is if your waist is over 80 centimetres, and in men if it's over 94 centimetres. This is a different way of measuring obesity because it measures where your fat is accumulating, and it recognises that people who carry their weight around their waist are probably at a higher health risk than those who carry it around their hips and thighs. So whilst us ladies may not like the fact that we have hips and thighs, they're actually to our benefit. Now, all of these are fairly gross measures of obesity. If you're an athlete, it's very likely that your BMI sits around 27 to 30. Most rugby players would have a BMI of 30, for example. But on the whole, it's a fairly good way of determining whether or not someone's obese. Rates of obesity, despite our best efforts since the 1970s when we had that Norm campaign, and I was interested to see they're trying to resuscitate that as part of the state election, but obesity, despite our best efforts to prevent it, has rapidly increased in Australia since the 1980s. There's in fact been an 81% increase in the rates of obesity in our country since 1980. And if you look at this graphically in Australia, you can see back in 2007, 2008, according to the Australian Institute of Health and Wellbeing, there was really only the states of Western Australia and New South Wales that had around 25% of the population who qualified as obese, and the rest of the country was lower than that. By the time we reached 2011, the whole country had kind of caught up with more than a quarter of the population being obese, and Queensland had moved to a new category with over 30 to 35% of the country obese. In the latest report from the Australian Institute of Health and Wellbeing, rates of overweight and obesity have continued to go up. For men, 28% of men are now considered obese and 27% of women. So it's a serious problem, and it affects a large proportion of our community. And it's not just our community that is suffering from this epidemic. The biggest nations in the world are probably in the Pacific Island, Tonga and Samoa. But USA comes in ahead of us, and New Zealand actually beats us. They beat us at rugby, but they also beat us in rates of obesity. And if you look at the rates of increase, the countries where there's been the biggest increase are actually Australia and New Zealand. So we're catching up very quickly to places like the USA in terms of this problem. But what does it really matter? Does it really matter if we are getting bigger? Maybe perhaps all we need to do is accept that the aesthetic of our community is changing, build bigger chairs, get airlines to build bigger seats, although clearly they're not getting the message. Back in the 1960s, you sat in economy class, you got a 17-inch seat. These days, you're more likely to get 16.5 inches, apparently. So perhaps we should just accept that and just move on, that the community's changing. We can't do that because obesity isn't just an aesthetic, it's a disease. It's recognised as a disease now by a number of august bodies, including the World Health Organization, the Royal Australian College of General Practitioners and Physicians, the American Heart Association, just to name a few. And it's a disease because it fulfills this very clear definition of what a disease is. And I'm just going to take you through this step by step so that I can perhaps show you that obesity isn't something that's a moral failing or gluttony or uncontrolled behaviour. It's genuinely a disease. So the first thing that a disease is it's an impairment of the normal state. Whilst I've shown you statistics that show that it's actually not normal to be in that normal body weight range, which is a BMI of 20 to 25 these days, that's historically not true. The word obese actually only came into the English language in the 1700s, and that was a literary term to describe excessive fatness. So because obesity was not normal, in fact in ancient times it was celebrated. This is Venus of Willenhorst. It's a little 11-inch figurine that was discovered in Austria. It probably dates from 25 to 30,000 BC, and it's a fertility goddess. So when women wanted to get pregnant, they went and touched this very precious item of this very obese woman who was obviously at that time very rare in the community and therefore celebrated. This persisted into the Renaissance period, where Rubens definitely celebrated obesity. Obesity was seen as richness. It recognised that people who could afford to eat more were the ones that were able to have that aesthetic. And this is a guy from the 17th century England, Charles Lambert, and he in fact became a very rich man by allowing people to visit him in his home and witness his large size. So obesity was not normal until very modern times. It is not a normal state. So it's not a normal state, and importantly, even if normal changes as it has in our society, it is a state that interrupts or modifies the performance of our vital bodily functions. There are at least 90 diseases that are directly caused by or made worse by obesity. And you'd be familiar with a lot of these, such as diabetes and high blood pressure, high cholesterol and heart disease. Cardiovascular disease is the number one killer in our community, and obesity is the number one risk factor for that disease. But you may not be aware that obesity is now the number one cause of liver disease in our community. We're now able to cure a lot of other liver ailments, such as hepatitis C, but we haven't been able to get on top of this non-alcoholic steatosis or fatty liver disease. It's become the number one need for liver transplantation in our community as well as in the USA. And it's an area of research for our department, recognising that, and I think Geraldine, who is in the audience tonight, who's led that research. It's also the number one cause of infertility in our community now. So there's more infertility caused by obesity than any other cause, both male and female. And it's also one of the number one causes of cancers. Many of the cancers that we commonly treat, including cancers that I treat of the esophagus, the number one risk factor in our community, and the reasons we're seeing increases in them is because of obesity. So obesity is important, not just because it's not important necessarily because of the aesthetic, and it's not particularly necessarily important because it's now become normal, but it is important because it causes ill health. Another part of the definition of disease is that there needs to be distinguishing signs and symptoms. And obviously a sign is something that you recognise as a marker of a disease, and the sign of obesity obviously is the shape that we see. And I alluded to before that really where you carry your weight is probably the most important thing. If you carry your weight around the middle, like a typical apple shape, which tends to be the male distribution of obesity, you're carrying a lot more weight near your vital organs. That puts a lot more pressure on them. Plus that fat probably produces a lot of different chemicals and hormones that puts extra stress on your body, and it becomes very unhealthy for a given individual. And finally, a disease needs to be a response to an environmental factor. Now that can be an infection, it can be your genetics, or it can be a combination of these. And obesity is really our perfect example of a multifactorial disease. It's caused by a whole lot of different things. At the end of the day, it's caused because a given individual's eating more calories or more energy-dense foods than they're burning off, so they're eating more than they're burning up. But there's lots of things that contribute to that seemingly simple equation. And partly that's your genetics, and there's a series of very elegant experiments that were performed in Sweden in the 1950s. I don't know if they could be performed now, where there were twins, identical twins that were separated at birth. They were followed up in the 1980s, and the body shapes of those individuals was almost identical. In fact, their weights were within 2 kilograms of each other, and it didn't matter where those twins had been raised, each of those siblings. And that just shows how powerful the genetics are. There's also your physiology that has a real impact on how you burn food, and there's certain times in your life where you're more prone to put on weight. For example, a period of life that unfortunately is becoming close to my heart, the perimenopause. People do tend to gain more weight because naturally the hormones that help you burn energy start to dissipate. We also have behavioural patterns that contribute to the reasons why people become obese. Very few of us eat because we're hungry. Most of us eat for lots of different reasons other than hunger. We use food to celebrate, we use food to commiserate, we use food to reward, to punish. We were told when we were children we couldn't leave the table unless we ate everything on the plate, otherwise, and to think of the starving Biafrans. So there's a lot of things that have been embedded in us since our childhood that make it very difficult for us to change and contribute to the reasons why it's very hard to lose weight and why people do put weight on. Gender, as I've said before, it's more likely that a man will become obese than a woman. A woman's probably more likely to worry about it, but the men are more prone to it. Socioeconomically, the disease is an obesity of the less privileged. Our lowest fifth privileged quintile are more likely to be obese than the most privileged. Psychosocial factors play into this. Depression, people are more likely to put on weight, and many of the treatments that we in fact offer for these diseases lead people to gain weight. And then there's society itself. We live in an obesogenic society. We live in a world where we're surrounded by food that's tasty, calorie dense, and we don't get sick from eating it. It's available 24/7. And on the other side of the equation, we really don't need to do anything to expend energy. We don't even need to get out of our chair to order that food. It'll be brought to us by Uber Eats. So we live in an obesogenic society where we don't need to do the things that we did in the past, and all those things are marketed to us very effectively so that we feel that we want them. So at the end of the day, we're living in a modern society, but we still have the same Stone Age genes that our ancestors had. We were born to be hunter-gatherers, but we now live in an environment where we don't need to do very much to fulfil our hunger. So obesity is a disease, and if we accept that it is a disease, it's our most prevalent disease. There's no disease more common. There's no other disease that affects 28% of the population. There's no other disease that causes more ill health. There's no other disease that causes up to 90 different comorbidities. And there's no disease that's more lethal. At least 400,000 deaths a year now in the USA are thought to be attributable directly or indirectly to obesity. That makes it more common now than smoking-related deaths. And your risk of dying, if you compare it as you go up that obesity scale using your BMI, once your BMI reaches that morbid obesity range of a BMI of 40, if you compare your risk of dying and you're morbidly obese to someone of the same age who's of a normal weight, your risk of dying is 3.5 to 4 times higher. So obesity is a serious disease and it deserves a serious solution. It would be ideal if we could prevent it, but we haven't done very well so far. Doesn't mean we shouldn't keep trying, but it also means that we shouldn't ignore that big part of the population that could benefit from weight loss. So how do we help people who are suffering with this issue of obesity? As I said before, at the end of the day, it doesn't really matter what the causes of obesity are for a given individual. It means they become obese because they're consuming more energy than they're expending. So in simple terms, we should be able to just reverse that equation and we should see people lose weight. It sounds really simple, doesn't it? And that's what all these diet and exercise programs are based on. But the problem is that diet and exercise programs alone don't work. This is a very old study now, but it's a very real study that shows that people who lose weight, most people can lose weight. In fact, 97% of people can go on a diet and exercise program, and over the time that they're having that intervention, they'll lose around 10 to 15 kilos. But over time, once they finish doing that diet and exercise program, whatever it might be, their weight inexorably drifts back up. And by the time they get to somewhere between 3 and 5 years, they're back to where they started, and then they usually add another 2 kilos. This is called a yo-yo pattern of dieting, and it's normal. It's true for 97% of people. So if it's happening for 97% of people, it has to be physiological. Really, only 3% of people are able to keep the weight off into the long term just by using diet and exercise. And the characteristics of these people are that they're essentially obsessive compulsives. They weigh themselves daily. They have an action plan or a disaster plan for the days where they've put on even half a kilo or 1 pound, meaning that they severely caloric restrict. They calorie count every day, restricting themselves to 800 to 1200 calories a day, which is basically 2 little entree-sized plates of food. And they exercise vigorously. And I'm not talking about going to the treadmill and walking and reading the magazine or watching TV. I'm talking about exercising to the point where they can't breathe. So that's a pretty big mission for most people. And most people have lives outside of their weight, and they need to think about other things like their kids, their schools, their whatever else it is, and they don't have time to be focusing all their energy and all their time on their weight management. The only 3% of people who tend to keep it off are people who turn their weight loss into their career. So if you follow up the people from the Biggest Loser program, most of them don't keep their weight off, but the ones that do are the ones who become the celebrity trainers, and then their whole life becomes focused about keeping their weight off. So why is it so difficult to reverse what should be a simple equation? Well, I guess it comes back to what I said at the beginning, that this is a multifactorial disease. There's lots of different things that are causing people to want to eat or to feel hungry, and it's very hard for a given individual to control all of those elements in their life for a lifetime. Because at the end of the day, when you lose weight, you get hungry. I don't know if any of you have had gastro and lost weight really quickly, or had the flu and lost 4 or 5 kilos really quickly. When your appetite comes back, it comes back with a bang. You feel really hungry and you feel like you don't want to stop eating. That's how people who've lost a substantial amount of weight feel all the time. When you lose weight, you lose fat, and that upregulates all your hunger hormones and downregulates all the hormones that make you feel full. So your body's fighting against you to preserve the fat in your body. I guess in evolutionary terms, we were designed to carry some fat so that when we came into times of famine, we had that extra energy reserve there. The trouble is now, or luckily now, we don't have those times of famine. So when we try to lose weight, your body fights it and wants to reinsert those energy stores just in case the famine's around the corner. So when you lose weight, you get hungry. And hunger's a pretty primitive instinct. It's very difficult not to eat when you're genuinely hungry. If you're at a restaurant and you've had to wait for your meal for 2 hours and there's a bread basket in front of you, it's really hard not to eat it. And on top of that, hunger and appetite and satiety are complex pathways in our brain. And we are very easily, even if we're full, we're very easily and capable of overriding them as human beings. So if you surround the fact that people who've lost weight are hungry, they're also surrounded by food all the time. So it becomes very difficult for someone who's lost a lot of weight to keep that weight off. So apart from just diet and exercise programs, we can try to help that weight loss, or at least help keep the weight off, by adding in some drug therapies. And there's been lots of drugs that have been tried over the years. You may be aware of Phentermine, Orlistat, which is called Xenical, which stops you from absorbing fat. They're around, but they're not used a lot because they do have some unpleasant side effects. For example, Xenical, one of the side effects is oily diarrhoea, which people really don't like. There are some new drugs coming to market which are looking quite promising. One that's just about to be released is a combination drug of bupropion, which you may know as an anti-smoking drug, and naltrexone, which is a drug that's used for narcotic addictions. And this drug's going to be called Contrave, and was actually invented by Michael Cowley, who's the Professor of Physiology at Monash University. It's looking to be a very promising drug and working on the addiction centres in the brain, and people can lose about 8 to 10% of their total body weight, which is about, if you weigh 100 kilos, means you could lose about 10 kilos. The other drug that's freely available at the moment or through your GP is 3 milligrams liraglutide. It's marketed as Saxenda. It's a hormone that the body produces that helps switch off your appetite, called GLP-1, and you inject that every day. So it's a little injection every day. And again, if people use this in the long term, they can expect to lose about 10 to 12% of their total body weight. So if you're 100 kilos, about 10 to 12 kilos. So drug therapies can help. But at the moment, one of the most effective treatments we have to help people lose weight who are obese is bariatric surgery. And at the moment, bariatric surgery is one of the only reliable ways of durably sustaining weight loss. There are many options around for bariatric surgery, but the 3 most commonly performed in our community would be gastric banding, Roux-en-Y gastric bypass, and sleeve gastrectomy. The gastric band is a procedure where we, through a keyhole approach, fit a wee device that sits just below where the stomach joins the esophagus. And that means that instead of food just rushing straight down into your stomach, it takes about 4 pushes of this lower esophagus to push one mouthful past the band. This then stimulates all the nerve endings in that area that are normally only stimulated when you eat a ginormous meal, and it makes people feel full after eating a small amount of food. It's a very effective procedure, it's a very safe procedure. Paul O'Brien's here tonight, he's really a pioneer in this surgery, and we recently published our 20-year outcomes from this procedure, and I'll show you a graph from that very soon. But it's a very good procedure, but it is a procedure you have to learn to work with. It's just a tool to help people lose weight by helping to control that hunger so that they're not seeking food once they've lost weight. The Roux-en-Y gastric bypass is probably the grandfather of the procedures. It was first performed in 1967 and is now performed again through a keyhole approach. In this procedure, we divide the stomach, we divide the bowel, and then we bring the bowel up onto this little pouch of stomach that holds about 50 mils. And the food comes through a channel that measures about 100 centimetres. The digestive juices that are produced by your stomach, your pancreas and the liver all join into that food stream a little bit down the track. And it's this alteration in the way that food hits that digestive stream and how the pancreas works means that there's some changes in the hormones that again make people not feel hungry and make them feel like they only want to eat a small amount of food at a time, feeling satisfied and only seeking to eat that 800 to 1200 calories a day. The new kid on the block is the sleeve gastrectomy. In this procedure, again done through the keyhole, we physically remove 80 to 90% of your stomach, leaving you with a little skinny tube of stomach. This means we remove a part of the stomach that produces a hormone called ghrelin, which is the hunger hormone. So people feel profoundly disinterested in food after this operation, at least for the first 9 to 12 months. Usually after that, the body starts making a bit of ghrelin elsewhere because the body's cleverer than us. And so hunger does come back a little bit, but not the way it used to. It also means that this area here, that the esophagus, just like with the gastric band, is no longer pushing into a big reservoir, but into a little skinny tube. And so those same nerve endings that get stimulated by the gastric band get stimulated, and also the food hits the duodenum more quickly, so the hormones that make you feel full are also triggered. So all of these procedures are really designed to help people live on that 800 to 1200 calories a day that successful weight loss losers need to keep their weight off. And they do that by controlling people's hunger. There are various other procedures. This is an area that's always changing. We do a modification now of that Roux-en-Y where we just bring the bowel straight up onto the stomach. You can plug the bowel in closer to the colon so that there's less room for absorption of what you eat. And there's a more growing interest now in endoscopic therapies where we try to simulate those procedures that we do through the keyhole, through the mouth using the gastroscope. These are data from our paper which was published last week looking at the effect of gastric banding over a 20-year period. And this shows that people who choose to have a gastric band as treatment for their obesity will lose around half of their extra weight. So the weight that they carry above a normal weight, they'll lose about half of that. And they will keep that off for around a 20-year period. It's not, so far out to 20 years, it's not an easy solution, it's not a quick fix. People who have this procedure have to work with the procedure, they need to still eat the right foods, they need to learn to chew their food, they need to eat slowly, and they really need to engage in the aftercare program, just like the model of any chronic disease. But if it's done properly and done well, it's a very effective treatment. And with this very substantial weight loss, we see major improvements in people's health and well-being, which is sustained. It's important that it's sustained out to 20 years, and it's important that we have this evidence, and this is the first evidence of its kind, because obesity is a chronic disease. And if we take the gastric band off these people, they put their weight back on. So there's no point in putting someone through the risks of a surgical procedure if we're not going to offer them a very long-term approach and a long-term solution to this problem of obesity. And it's pleasing to see that the gastric band does that. But it's not just the gastric band that offers very good outcomes. This is a review we did as part of our paper. There wasn't any other 20-year papers, but there are a number of reports out beyond 10 years now for the Roux-en-Y bypass and its modification, the one anastomosis, the LAGB is the band. BPD is a procedure we don't do so much anymore. The sleeve gastrectomy, if you just focus on those three, all of them offer around about 55% excess weight loss, the same as the band, out beyond 10 years. So they're all very effective procedures. They all seem to be relatively durable beyond 10 years. We don't know much beyond that, but the 20-year data is promising, and they seem like they're a very good solution in terms of weight loss for people who are suffering from this chronic disease of obesity. But it's not just weight loss that's important. As I said at the beginning, what does it really matter if we're getting bigger? Just make bigger chairs, make bigger things. The reason we worry about obesity as doctors is because of its effect on health. And we now have an increasing body of evidence that shows that with this weight loss from bariatric surgery, there's substantial and significant improvement in health. There's now 15 randomised controlled trials, which is a trial where we compare one therapy to another, that demonstrate a benefit for diabetes in patients who've had bariatric surgery. Bariatric surgery is undoubtedly the best treatment for obese people with diabetes. There's also one trial that we performed here at the Alfred through Monash University in Core, showing a benefit also for obstructive sleep apnea, which is also a major health problem in our community now. And there's a number of other studies, including many from our own group, showing real benefits for people who have bariatric surgery in terms of their arthritis, their liver disease, their polycystic ovarian syndrome and infertility, depression and cancer. So both men and women who choose to have bariatric surgery as a treatment for their obesity can expect major improvements in their health, but also major improvements in their quality of life and sense of well-being, which is really important. All of these improvements in health translate in the end to fewer cardiovascular events overall, and these are data from the Swedish obese subjects study, which compared 2,000 patients who had obesity surgery in the 1980s to 2,000 obese patients who didn't. Sweden's a little unique in its ability to track its population through their health records, and they've got very good follow-up of these patients. And what they've been able to show is those that chose to have surgery had far fewer fatal cardiovascular events and total cardiovascular events, meaning heart attacks and strokes, when compared to the group that didn't have bariatric surgery. This therefore means that people who've undertaken bariatric surgery have a lower risk of dying when compared to obese persons who do not have bariatric surgery. And that risk of death is up to the magnitude of 90% lower risk. In our own study from here in Melbourne at Core, again led by Paul O'Brien, this showed that patients who'd undergone gastric banding when compared to a group of obese women that were being followed through a Mediterranean diet study, that the risk of dying in the group that had bariatric surgery, in particular gastric banding in this case, the risk of death was reduced by 72%. So obesity is a disease. Weight loss is an important intervention to help people improve their obesity and all the health-related issues that go with obesity. And bariatric surgery is a good option for offering that weight loss. As I've shown you, it delivers very clear benefits to health, and importantly in the society we live in, it's also cost effective. There was a study that was performed a few years ago now in Queensland that compared every single preventative strategy that's ever been undertaken in Australia. They looked at road rules, they looked at helmets on bikes, they looked at smoking cessation, they looked at alcohol, and they looked at obesity treatments and preventative strategies. In that suite, the only cost-effective intervention was bariatric surgery, and the magnitude of cost-effectiveness was the same as tobacco cessation. So treating people with obesity whilst with a procedure obviously has a cost up front, but the community gets that cost back in folds because we do make people healthier. Importantly, bariatric surgery is safe. There's no point in doing an operation to make people healthier if we kill them doing it. And when we look at the mortality and the morbidity meaning the side effects or the complications of surgery, the sleeve gastrectomy, the gastric band and the bypass, they are all extremely safe. The band is the safest, the sleeve is somewhere in the middle, and the bypass, because of the complexity of way we rejoin things together, is probably the slightly riskiest. But all of these are in fact safer than doing a laparoscopic cholecystectomy or removal of your gallbladder. You'd think that it would be riskier because the population we're operating on are bigger, they're heavier, they should have more anaesthetic risk, but it's a very well tolerated surgery, and these are results that have been replicated around the world. Also replicated in our own National Bariatric Surgery Registry housed here at Monash University. And in our registry, we've shown that the adverse events in patients who undergo any of these bariatric procedures when it's the first operation is extremely low. It's 2.4%. We've got 60,000 patients on the registry now, and so it's a fairly solid data source. So it's very safe surgery, so people shouldn't be afraid of it. You should only operate at the last resort. You should only cross the road if you have to, because there is always risk, but it is very safe. The other thing that bariatric surgery offers us, apart from the improved health of the individual, is it is a very durable and effective way of keeping weight off. And if we can understand why, maybe we can find a treatment that translates better to the general population. I, as a surgeon, and the other surgeons in the audience, couldn't personally operate on every obese person in Australia. It's just not possible. But if we can find a treatment that translates from what we've learnt from bariatric surgery, then that could be really exciting. And one of the great things about working at Monash University, and particularly in the Central Clinical School, is we get to work with some really amazing basic scientists. And so we've done a suite of studies, starting with Paul Burden's work a few years ago now, trying to understand the pressure changes when people have surgery with a band or with a sleeve. We've translated that into information videos for patients that show how the food gets past the band. And that's that pushing motion I was telling you about, squeezing and triggering all those nerve endings. But then we've worked with basic scientists who've been able to do a model of the gastric band in mice, inject a sort of herpes virus into that area, and then track back into the brain exactly the parts of the brain that are being affected by the gastric band. And then through that be able to zone in and see, are there drugs that we can develop or other gene therapies or something that can help stimulate that same sensation of early completion of meal or satiety and that long prolonged feeling of satiation or desire not to eat. So bariatric surgery has become a very important research tool in a way because it is such an effective therapy. But this is our challenge. In our community, 28% of our population are obese. That means roughly, 2 million people. And so far, we operate every year across Australia on about 25,000 people. So we're operating on about 1% or less of the potentially eligible population. This means there's an enormous amount of the population or this group that don't have access to this treatment of a bariatric surgery or any other treatment for that matter. So this is a real challenge, and if we add to that the fact that 93%, and then again this is data that comes from our registry, that 93% of bariatric surgeries occur in the private sector with only 6% of the procedures occurring in public hospitals, it makes access to bariatric surgery a real issue for our community. We have a very effective treatment, yet we're really not helping as many people as we could, and we're certainly not helping people who don't have access or able to access private health care. And this is an issue because, as I said before, obesity is a disease of the more predominant in the disadvantaged. According to the latest health survey in Australia, 66% of people in the most disadvantaged fifth of the population are above a healthy weight, as opposed to 59% in the most privileged. So there's a real need for the public system to address not just bariatric surgery but other obesity treatments. But the risk is it could overwhelm our resources. We could probably fill every operating theatre at the Alfred Hospital every day doing obesity surgery, but we still have to do our cancer work, we still have to do with road trauma victims, we still have to do heart transplants. So how do we fit in a treatment for a prevalent disease within a public health sector? And I guess this slide also highlights that those who are actually getting access in the public system are our sickest and heaviest patients. This is a slide again from our register that shows every hospital in Australia undertaking bariatric surgery and the mean BMI of those hospitals. The red bars are the public hospitals, and you can see the ones with the highest BMIs are all in public, and they've got a mean BMI of 50, so that's super obese group. So the group that are actually getting care in our hospitals are our sicker and our heavier group. Alfred Health has a proud tradition of offering public bariatrics. It started back in the early 90s when Paul O'Brien joined the group here. And we built up a very successful service, but we got to the point where we've got about 600 primary care referrals a year, plus another 150 in-hospital specialty referrals. We had a major increase in what we were able to do in terms of the numbers we were allowed to do, from 50 to 150 in 2010, but we still had 636 patients waiting for their first appointment, which meant they were waiting 7 years to see me in the clinic. On average, they were gaining 5 kilograms while they were waiting to see us. And strangely, even though they'd waited all this time, 12% of them failed to attend their first appointment, which was wasteful. So we took a pragmatic approach to this and thought, how can we improve it? With the support of our CEO, Andrew Way, who's very supportive of our program, we thought a little bit outside the box and thought, what can we do differently? The traditional model of how we care for people in public hospitals is we bring them we get a referral from the GP, we give you an outpatient appointment, then you go onto a waiting list for surgery. So what we decided to do was to put a bit more of the care out into the community. We developed a structured tool for the GPs to fill in that made them go through a series that covered not only the causes of obesity but the complications of obesity. We also got the patients to complete a health questionnaire that allowed us to triage whether or not we thought they needed to be done more urgently or not. Once they got triaged, they got offered a patient information seminar where we talked to them about the problem of obesity and what different options are available, including surgery. If they decided to proceed, they went on to an online learning program with 16 modules. And then once they'd completed all that, they got offered an appointment in our weight management clinic and either got surgical treatment or medical treatment. So this was really quite a novel way of starting care and patient education before first appointment. We decided, because it was very novel, that we would do it as a study, and we compared 82 patients in our new program to 61 patients that were going already on our waiting list for surgery. They were at baseline very similar. The predominance of females, which is typical of our hospital, similar age, and most of them had gastric bands, as was our practice at the time. And what we found was that 100% of GPs completed those referrals. 89% of patients went on to attend an information night. 100% had a go at our online learning package or on the booklet form. And there was only 14% that really didn't do very much at all. And by the time we got to first appointment, that 12% fail to attend rate had dropped to 2.1%. And we found that by the time they got to that point, about 5% of patients were not suitable for surgery, so were treated through the medical arm. Patients were very satisfied with the process, and interestingly, although we weren't aiming to do this, over half of them lost or maintained their weight whilst they were doing this program. So rather than in the past them putting on weight whilst they were waiting to see us, they were actually losing weight. This meant that from those 636 patients at the outset, about 427 patients got to the point of wanting to move on from their filling out their questionnaires, and ultimately there was 229 patients that went on to have a first appointment. There was a large dropout rate. There was a large lot of people who decided it wasn't for them, but it's probably better that they decided that before they used up a precious outpatient appointment. And in some ways, we think that's probably pragmatically a good thing. There was significant improvements in their attendances after surgery as well when compared to the group that didn't have surgery. Their fail to attend rate didn't have our preoperative program. Our fail to attend rate significantly dropped from 11% in the group that hadn't gone through the program to around 4% in the group that did. And importantly, the weight loss in the group that had gone through our program was significantly better than our group that didn't go through the program at 1 year. So by educating our patients better and engaging them from the outset, we were able to show not only better attendances, but better weight loss outcomes. There was a dropout rate, but maybe it was the group that were looking for a quick fix, and none of these things are quick fix. You can't have a band strapped around your stomach or have your stomach cut out and magically eat McDonald's every night for dinner. It just doesn't happen. You do have to see this as a whole of lifestyle change. People do have to change what they eat and how they eat. And so maybe they were better prepared. So by introducing this program, which has been quite novel, and it's been a real, I think, really great thing for us to be working in the Central Clinical School and the Alfred, is that we were able to change a model of care, but do it in a way that was informed and measured, and we were able to look intelligently at the outcomes. And I think this is what translational research is about. And by doing this, we've been able to achieve better flow of our patients and better outcomes. But we still live in a world where demand continues to outstrip supply. This year we've had 800 referrals in the first 6 months of this year alone. And I think this reflects the fact that it's increasingly difficult to access the surgery privately due to private insurers changing their structures and the cost, but also probably there's an increased awareness of the efficacy of the surgery. So our ongoing research looks at, are there groups we should be prioritising in a public health setting? Is this approach cost effective? Is it worth the community supporting? And how we can keep up with the need for aftercare. Because we see all of these not just as a procedure but as a lifelong process, and they do need to be supported by best aftercare. So the question remains, how can we improve the uptake of bariatric surgery? The Alfred has, I guess, taken a head-on approach and said, right, we're going to do this, but we're going to do it in a way that we think is educated and informed by data and, I guess, pragmatic. But how as a community are we going to respond to this problem we have with obesity, where 28% of the population could do with some serious solutions to their weight problem with weight loss? I think for both medical and surgery, to achieve this, we have to start looking not just at equality of access, but also equity of access. And we have to start looking at different groups that are suffering from obesity and looking at different ways of helping them, so that we can try to give people access to treatments that are going to be effective. And to achieve this, the first thing we need to do is engender some public empathy. It's still considered a little bit of a moral failing to not be able to lose weight. My patients constantly cry when they come to talk to me because they feel like a failure that they haven't been able to keep the weight off. They usually tell a story of how they've lost weight but haven't been able to keep it off. And they feel judged and they feel victimised and stigmatised, and they are. It's the one group in community that people still do have value judgments around. And that's not fair because, as I've shown you, it is a disease and it's a very, very difficult thing to keep weight off into the long term. So I think to really change things, we need to engender some empathy in the community. If you think about the example of depression, a few years ago, people used to just say, buck yourself up, pull yourself out of it, get the black cat off your shoulder, just get on with it. These days we recognise that it is a disease and it needs a proper treatment. And I hope that obesity soon will be in a similar situation to where depression fits now. Because obesity is a disease, it's our most prevalent disease. It causes more ill health and lack of well-being than any other disease in our community, and weight loss is a very powerful health tool. Bariatric surgery is a very good way of delivering that weight loss, and we can learn from bariatric surgery and hopefully develop new treatments that will be more deliverable across the community. But for now, we need to be thinking about these individuals and thinking now, what can we do to help them? And that's our challenge for the future as we move forward, to how we can improve access to these treatments so that more people can benefit from the health benefits that come from weight loss. So I'd like to thank you again all for coming tonight, and I'd like to acknowledge my colleagues both here and at Monash University and internationally that we collaborate with. I particularly like to thank Julia and Matt and Daphne and Alison for their hard work in pulling this all together. You've really done a great job, and thank Steve very much for the privilege of delivering the lecture, and also acknowledge the hard work that goes into our bariatric surgery registry that sits here at Monash University. So thank you very much.